It is absolutely my pleasure to introduce Dr. Jeanette Ives Erickson, who is here today. And I said to her, what part of this do you want me to say? And this honestly could have been 3 or 4 pages long at least. And she said, oh, just say I'm an alum of the Westbrook College here. And I want to say that we're just thrilled to have her as a friend again of UNE and our interprofessional efforts and our nurse leadership efforts. But I'm going to actually say a few things to give them a little sense of your accomplishments. She is a Senior Vice President for Patient Care and Chief Nurse at Massachusetts General Hospital. She's an instructor at Harvard Medical School, a visiting scholar at Boston College, Senior Associate at the Institute of Nursing Healthcare Leadership, and assistant professor at the Mass General Hospital Institute of Health Professions, which is doing remarkable programming, very exciting programming there. She has a number of awards to her name. One of them I want to point out was that she was the inaugural recipient of the American Organization of Nurse Executives PRISM Award. And what the PRISM Award recognizes is the promotion of diversity within the nursing workforce, and I commend you for that. And with that, I'm just going to turn this over to you. Welcome.
Well, thank you. I'm wired. Thank you. It's really wonderful to be with all of you. And what I wanted to do today is to share some early work that we're doing regarding interdisciplinary care delivery models. Would love to have a dialogue about it, get your feedback on how perhaps some of the work that we're doing could apply beyond the acute care hospital, and then to share with you where we're headed with this initial work. You'll see that the logo on my slide is not the Massachusetts General Hospital logo. It's the logo of the Lunder-Dineen Health Education Alliance of Maine. So I want to begin by sharing with you that there are 3 fabulous women in the room who are resources to you as students as well as care providers. I'm going to ask them to stand, but I'll start with the pink scarf is Denise O'Connell, then Carol McKenzie, and Labrini Nelligan. And they are people that really do all of the work of the Alliance. The Alliance is a gift from an MGH grateful patient who is from Maine. And these patients gave us the gift to build a new inpatient facility at the MGH that opened 2 years ago. And the stipulation was, as I was sitting on their porch in Scarborough, Maine, the stipulation was we would love to advance nurse physician education in the state of Maine. Can we take the education that's happening at the MGH and extend it to our home state? And I said one stipulation on this is that we need to extend it to all the health professions, that we needed to make sure that the interdisciplinary team really were learning together and on the same page. So over the last few years, we have been there's no we in this. They have been meeting with people from healthcare facilities from Fort Kent right down to close to the New Hampshire border, asking people what their learning needs are and what we might be able to do to help. This past year, we've been doing geriatric education throughout the state and have been meeting with veterans groups as well. The MGH also has a wonderful initiative called the MGH Red Sox Foundation Home Base Program, and it's for returning veterans from Iraq and Afghanistan. So we have also been meeting with veterans and looking at what some of the educational needs are. So we wanted them to be with you today so that you would have names and faces as you think about developing your own practice in developing your continuing education needs, that you would think about this resource that's available to all of you. So I'm glad they're here. So I'm going to talk about the Interprofessional Dedicated Education Unit and what we have been doing over the course of the last year and a half and where we are going. Prior to thinking about having an interprofessional DEU, we had regular dedicated education units that are common throughout the country in nursing, which are in fact nursing students paired up with staff nurses working on the same unit. We felt that the future of healthcare required a team approach, and in fact, we should be learning together before we practice together, which is actually what this university is about, right? It's all about interprofessional education and the importance of learning together. So I'm going to talk to you about the rationale for our work, talk with you very specifically about how this evolved and how we're moving forward, and then talk about some of the early lessons learned. We began talking about interprofessional education and interprofessional care delivery as we were thinking about what I would say is the tsunami of change that's coming to healthcare because of the Patient Affordability and Protection Act. We're fortunate to come from Massachusetts, where we've had healthcare reform for a few years, and we've understood the importance of advancing the 6 aims of the IOM, right, to make healthcare of higher quality, safer, efficient, effective, equitable, to deliver care in a timely manner, and to make sure that it is patient-centered. We have been under significant pressure to reduce costs, to enhance throughput, to look at ways to care for patients outside of hospitals. And so we've created a new patient care delivery model, which I'm not here to talk about today, but also decided that if we were going to advance our delivery model, we needed to change the way we educated the next generation, but also change the way in which our clinical staff were approaching care delivery. So as you know, there are huge gaps in the way in which healthcare is not only delivered in this country, but in the way in which we are prepared to deliver healthcare. Professional education has not kept pace with the changes, and in fact, the Institute of Medicine did a report almost a decade ago about the need to change health profession education and to make it interdisciplinary, and yet very few schools have done anything about it. Very few healthcare organizations, hospitals have done anything about it. We still have physicians going off to learn anatomy and physiology over here, nurses, pharmacists, therapists, all in separate classrooms. And the last time I looked, the anatomy was the same, right? So why don't we even take advantage of some of the common things where we could learn together, let alone patient safety, teamwork, resiliency, conflict resolution, etc. So education is really fragmented, outdated, and I would say in most organizations very static. And yet we have systematic issues that need to be addressed. Competencies are not really rising to the level of how acutely ill our patients are, whether they're in the home or whether they're in an intensive care unit. We think about the home hospital. How are we preparing people with new competencies? How are we preparing people to even practice in isolation? How are we preparing people to be care managers, care managers across the entire patient journey, no matter what discipline we represent. And how do we think about not only interprofessional education and care? I've started doing some work looking at transdisciplinary approaches to care delivery, where as a nurse, I might be able to share common competencies with another discipline. So how do we think about multitasking in a way that benefits patients and families? And we're not going to do that unless we get educated together, whether it's in this classroom or it's at the bedside or in the patient's home. So when we think about more evidence to support interprofessional education, we think about the silos, as I've already talked about. We need to think about why errors are occurring. Why are errors occurring? There's actually a wonderful piece in the Boston Globe today about research coming out of Children's Hospital in Boston about handovers from discipline to discipline, shift to shift, organization to organization, and how patients are falling through the cracks because we're all rollerblading through healthcare and we are not talking together at a very standardized or consistent message. And so if we're going to think about reducing medical errors, 66% of which are attributed to communication breakdowns, we need to learn how to talk together, and we need more consistency in that. And then as we think about coordination, we think about, you know, I was an intensive care unit nurse, and I worked with that wonderful surgeon right there, Dr. McAfee. And when I think about those patients that I cared for 1,000 years ago, they're probably at home now. Many of them, as an intensive care unit nurse, those patients are being treated in skilled nursing facilities, they're on ventilators at home, they're in step-down units, they're not in intensive care units. So how do we think about this, the complexity of the patients and the complexity of the systems, and yet if we don't know how to maximize each other's skill sets, we will just continue to work in a very fragmented system. So think about what I said about the interprofessional communication regarding errors and near misses, and even what could be prevented earlier in the system if all eyes were looking at the patient in a very coordinated way. We have to think about standardized language. As a nurse, I've been challenging many of my colleagues to stop the nurse speak. Stop the nurse speak. Let's talk in common language. Let's talk to patients at the patient level, and let's talk within the team as a team, and stop the nurse speak. Think about what's best for the team and for the patient. And we also need to think about, we can decrease errors and near misses by thinking about the responsibilities and the integrity of the team. One of my favorite nurse researchers, Patricia Benner, talks about domains of practice. And so in probably 10 years ago, we introduced this nursing research of Benner's regarding the domain of nursing practice, and asked all of the disciplines to articulate their domains of practice. And then we had different disciplines present to auditoriums full of care providers. And at the end of the day, what we realized is that each discipline was articulating what they could do for the other discipline to help with advance the care delivery of patients. And it was a very interesting moment, because we understood that while we're working side by side, we really don't understand what each person could do to maximize the patient experience. We actually now have moved this work on to our support staff. Our housekeepers and our unit secretaries just presented the other day about what their domain is, and actually said to several of the people, the housekeeper said to several people in the room, you know, I actually spend more time with the patients than any of you do, which is true, right? We go in and out, in and out. They're in a patient's room cleaning for half an hour, and the patients talk to them. And quite often they speak the patient's language. So this person said, so I spend more time with the patient than you do, and I'm believing I could help with this reduction in patient falls in this hospital. Is that like a whack on the side of the head? I'm in the patient's room while they're tripping over the linen hanging off the bedside. I'm in the patient's room when they're trying to get up and you're busy in another room. I can help you to reduce patient falls. Interdisciplinary care. Interdisciplinary care. So the Joint Commission, when we think about their work looking at patient safety concerns, we all know them because we live with all of those concerns. But look at the number one concern is when looking at root cause analysis, it's regarding communication. And then the second one is regarding orientation and training. So if we fostered better communication, we're thinking about improvements in patient safety, which should be good enough for all of us. Patients would be safer. But oh, by the way, errors, hospital-acquired conditions, problems in the patient's home, all cost the healthcare delivery system more money too. So if we're going to provide access to all Americans, we need to think about how to reduce healthcare costs so that in fact we can afford to pay for the uninsured. When we think about other research and we look at the association between nurse-physician collaboration and negative patient outcomes, we look at the negative outcomes with a predicted mortality. The higher level of collaboration, the lower risk of a negative patient outcome. It all gets back to the importance of building interprofessional teamwork at the educational level so that when you're in practice, you really are in fact comfortable being in the middle of the team. So when we look at our work, we've been talking about a patient-centered approach that maximizes the strengths and the skills of every healthcare worker. And when we look at interprofessional education, we think that it needs to occur when learners from two or more professions learn together and really understand each other's work and work together to improve health outcomes. So we talk about a process where we are including collaborative practice elements of responsibility, accountability, coordination, communication, cooperation, assertiveness, autonomy, mutual trust, and respect. And a lot of it has to start with the very last one, right? Mutual trust and respect. Because if I respect you and I trust you, then I'm going to feel comfortable having a collaborative relationship with you and asking those questions that we don't now dare to ask each other. If I ask you the question, you'll think that I just don't get it. So this is a framework for action that came from the World Health Organization in 2010, where they started picking up the work of the IOM and said we really need to move forward the ideas of this interprofessional education and think about collaborative practice, not just in the United States, but across the world, especially in resource-poor facilities, resource-poor countries, that you needed to maximize the entire healthcare team. And so to take everything into context based on the local culture and what the healthcare needs are of those that we are serving. And think about the present, the future healthcare workforce and how you can take a fragmented system and bring it together into that middle, which is the collaborative practice reality, and how that new reality would move things forward to optimize health and health services, so to strengthen the entire healthcare delivery system. I think when you think about interdisciplinary care, interdisciplinary education, doing a deeper dive on this report would help you to think about what you want to advance, and then maybe you'll win the $3,000 as well, because they do have some good ideas. This interdisciplinary or interprofessional collaborative practice and education is not just something that's being endorsed at the University of New England or at the Massachusetts General Hospital. Look at the professional associations that are saying we need to move on this and we need to do this. These are all of our organizations that have come up with core competencies for collaborative interprofessional practice. They are talking about the goal as being key to safe, high quality, accessible care, and really built around constructs of values and ethics for practice, really pushing the envelope on roles and responsibilities, again, communication and what teams and teamwork can in fact do. So now I'm going to get into the specifics of what is happening at the Massachusetts General Hospital. Our interprofessional dedicated education unit is in collaboration with our own school, the MGH Institute of Health Professions, which is a school that doesn't have as many disciplines as this school does. School of Nursing, which is undergraduate, bachelor's, master's, and doctoral school, a new PhD program in health research, rehabilitation research, physical therapy, and speech-language pathology. 2 new programs being added next year, physician assistant and occupational health. You have much more than that here. So we started collaborating with them. It is our school to think about this interprofessional unit. So here's taking from the nursing model, you think about staff nurses becoming clinical instructors who are nurses, then the research would say are more skilled in coaching and do a better job at working with students. Then the students and the nurses and everybody on the unit benefits because why? First and foremost, students are saying why. That's why I love working with students. Why? Why do you do it this way? Because we've always done it this way is not the right answer, right? The why and the explanation, and coming from a knowledge set as well as experience of the people at the bedside. And the outcome that we realized we have 2 nursing dedicated education units. I should preface with the University of Massachusetts in Boston. We've had those for about 10 years. We've been able to hire those nurses as registered nurses in our hospital. We knew them. We understood who they were. They understood the team. And oh, by the way, they didn't require as much orientation on the unit because they just spent 4 years there. So what did we do with all of that money that we were able to cut from orientation? We put it in a pool and we now are funding scholarships for the students. You know, it's a great alliance. So the other part of the DEU is that the experienced nurses become better at, and I don't mean clinical supervisor as a role, I mean as someone who has a broader picture to oversee care delivery. And then they begin to educate not only at the bedside, but now they are influencing care across the continuum, and now they are becoming educators. So we took that idea and said, if you were going to move this work forward, and it was interprofessional education, then how do you take the lessons from nursing and apply it to all disciplines? It didn't take very long for all disciplines to say, we want to do this. We want to learn how to precept, so we put all of the disciplines through how to teach, how to precept courses. They feel that they are stronger at it. And then we began to bring everybody together in collaborative meetings, thinking about how would we go about doing this. And we realized that everything that had been said by the IOM about learning together was right. Patients were better served, communication was enhanced, and people's radar were heightened regarding the possibility of errors and what each discipline could do for each other. So we began on what some people were shocked at was a cardiac surgical step-down unit. Some of the sickest of the sick, heart transplant patients, bypass patients, patients that have been on ECMO, have been ventilated, who have stepped down onto this 36-bed unit. The success said we now need to see if we can take this work from a specialized unit into a very busy general medical unit. And this 24-bed medical unit is, I was surprised when I went to the MGH and saw some of the patients that are being cared for in our general medical units. There are a lot of homeless people. There are a lot of people with mental health disorders, a lot of the chronically ill medical patients that are on this unit. And we thought if we could really apply this model to this unit, we could then say, all right, where would we go from here? We had 24 students in our first unit, the cardiac step-down unit, from communication, science disorders, nursing, and physical therapy. We did not have any physicians. We didn't have medical students or residents in this original unit. And we knew that that was a flaw at the time, but at the time we were launching this, we had a new chief of cardiac surgery coming who was making a significant number of changes, and we didn't want to slow things down, so we moved ahead, and he was supportive of that and is now jumping into the fray, wants to have his residents and his fellows as part of this work. So the goals as we began to do this work was very similar to what I've talked about before, was to really look at clinical education. How would we educate people in the interprofessional collaborative way, and what patient outcomes did we want to improve? How do we look at the professional and interprofessional activities and competencies? How do we learn each other's competencies? What are the goals that the instructors had for each of the students? Was there actually any alignment for what the goals were that the instructors had? Because even though they were from the same school, they didn't even know what their own goals were for each other's student. So that work began to unfold. We, of course, had a selfish reason at the MGH because we wanted to make sure that we were creating the next generation of clinicians for the Mass General. We also wanted to make certain that our own clinical instructors, our own staff, received some level of education, new learning for them, so that they were better preceptors. Because even if this experiment failed, we wanted them to come away from this as better teachers. And of course, we wanted to increase everyone's understanding of what each discipline brings to the bedside. So our clinical day structure was complicated at best, because lots of people were saying, well, we can't have the same patient assignments that we had before because we have to have these students. And my job was to say, well, there is no money for this, and nobody's going to give us any additional staff, so we better figure this out if we really want to do this, right? So the team did, in fact, figure it out, that there are students that are with either a staff nurse or a staff physical therapist or a speech language pathologist, and depending on what the patient acuity is, the other staff were moving in and out. So I, as a nurse, if I would normally have 4 patients on this unit, but my student was a real novice, first day in this unit, everybody on that unit knew there was no way I could take care of 4 patients and still teach this. So the unit figured it out, and assignments fluctuated dependent upon where the student was in their own role development and where the patients were from an acuity point of view.
Can I ask questions? So I thought with the accreditation, because we've run into this issue implementing these kind of rotations here in Maine. And so one of the issues I think we've run into, and I don't know if anybody from nursing's here who can just correct me if I'm wrong on this, is the accreditation requirements require nursing students to be precepted by a nurse, so that you can't have a nursing student get precepted by, say, an SLP or somebody, or an OT or somebody else. So I just wondering if you could quickly say how you address that issue.
Thank you, and I should have talked about that. So because there are licensed clinicians, there are nurses that are part of the program, speech and physical therapy, everybody is watching out for each other. So if you're performing as a nursing student something that's in, I as the nurse, my skill set, I am with you. But if we want to teach the nursing student about restoring swallowing function for a patient who's just had a stroke, we put the speech pathologist in the middle of that conversation so that they are learning from the content expert. So the alignment is there from a regulatory point of view, which, by the way, I guess I'm being filmed, is totally outdated, right?
Yes, thank you.
Totally outdated. If we're going to take care of patients the way they need to be taken care of, you know, healthcare is a team sport. And so it's far better for me as a nurse, no, it's far better for me, the patient, to learn how to swallow again from a speech pathologist than it is from the nurse, right? And then if I'm having difficulty with mobility, who's better to help me? The physical therapist, right? And yet, I as a nurse should be learning mobility from another nurse and not from the physical therapist. So we've aligned this to go with regulation, but students are learning from the experts in each of their competency development. So thank you for that.
Thank you. That was helpful.
So, well, and this would actually help with that. So if we really are looking at patient and family care, we tried to think about how do we engage students across all those disciplines so that we were talking in groupthink about all of the issues that our patients were facing. And so this is but one. And many of these elements go across all patient populations, but as we go to the next unit, we look at this and say, all right, maybe there's not patients with swallowing issues, but there are ethical dilemmas on where we're discharging all of these homeless patients, right? And so then we talk about that. So all of that changes based on where we're at and what the patient population are. But all of the students are engaged in the conversation, and that's why they can learn from each other while still maintaining regulations. So our evaluation plan, our evaluation is underway. So students are writing, if you will, narratives about their experience and what it was like before getting onto an interprofessional DEU and what it was like based on that. And because we have a narrative process based on Benner's work of staff telling their stories, we have people who are experts at unbundling qualitative content. We are working with the IRB right now to approve our research study, and we are looking at what additional research questions we're going to ask. And we have sort of slowed this down because the hospital is in the middle of a strategic planning process, and there are 4 strategy groups that are looking at episodic care, population health management, research, and education. And the education strategy group embraced rolling out interprofessional DEUs throughout the whole hospital. And so now the Harvard medical students will be a part of this. So it's really good news. And now we're looking at how will we align with a school that has a pharmacy program? How will we align with the other disciplines that we don't have with the MGH? And we're not going to just stay having interprofessional DEUs with that one school, because we have like 5 core schools in Boston that we work with, and we have students from around the country that spend, well, students from around the world that spend especially summers with us. So how will we move this forward? But the Harvard medical students and residents will now become a part of this. So the learning outcomes that the students are telling us in their narratives is that the teamwork needs to be built into professional practice, and it is. That teamwork is now at a higher level, and that they are really able to address ethical dilemmas in a new and different way. That communication has in fact been improved, that the staff themselves, the students are saying the staff themselves understand the student role better than they ever did before, that there's more of a give and take versus the burden of having students on your unit, that it's a welcoming. And we are really looking at now, as I just said, the roles of the team members and the differences going forward once we start to build in other disciplines. These are comments that I culled from some of the narratives. All of the disciplines blend in a way that supports patient care. The patient would not receive the best care if it weren't for the interprofessional practice. I mean, that's my favorite, right? The patients are getting better care. I have a better understanding of what my role is with physical therapy and speech-language pathology. That was from a staff nurse. I think the debriefing sessions were influential. It was great having all of the disciplines present and hearing their perspectives and contributions to difficult problems. The end of each day, there was a daily briefing for the first cohort, because right? You either adapt, adopt, or abandon an idea. So we wanted to make sure that at the end of each day, we were advancing our objectives. And if we weren't, we were either going to adapt or abandon. So we had daily debriefings. Now they are weekly. So future directions and considerations, and why we probably want to talk is, of course, the implementation of other disciplines, the expansion of this beyond the 2 clinical units, and what about the model will need to change? What if we're in our emergency department, or in one of our 12 intensive care units, or we're in ambulatory practice, or in one of our health centers? What about the model will have to change so that we still have the same outcomes? And then how are we aligning, and this is part of the research study, how are we aligning the impact of this model to patient outcomes? And then what are the implications on interprofessional practice, and I should say interprofessional education as we go forward, because a lot of the education in the classrooms is still siloed based. So how do we break through those barriers so that the anatomy I learn is the same anatomy that the pharmacist learns? So that's where we are at. We're in the infancy. Some of the initial evaluation data is looking good, but before we launch this mega research study, we want to now look at how we're going to bring our physician colleagues into this work. So I would welcome your comments, your feedback, and your questions. Oh, I thought a very brave woman. She's right up.
Hi. Listening to your presentation, I think I understand that this is a clinical-based approach to interprofessional education, and that you're working with a variety of students from all disciplines. They come to you from various locales. So your presumption would have to be that the students may or may not have an awareness of interprofessional competencies or the need for interprofessional education when they get to you, and your system's prepared to work with that. Thinking about an educational institution, what could a place like UNE do to send you what core competencies would you like to see in students when they arrive that would allow you to get a jump off that would be exponentially helpful?
That's a great question, and I'll go back to Dora's comment. First, the competencies that you have to have, right, from each of your professions. But I want to see people who really understand change and want to contribute to change. And so and that's what we did in the beginning with our first group, was even to introduce change theory to them. And the whole idea of rapid cycle change, so you're all talking about the IHI, right? So what does rapid cycle change mean? Because you're not going to do any of this at the expense of the patient. So how do you create freedom to work in an environment that's fast-paced, very high acute patients, where we want to have change and we want to bring down the barriers? So we want the best of the students. And we had the luxury, right, having the very first interprofessional DEU, to have students apply to be a part of this. And so we got to pick who we want. We won't ever do that again because we want to roll it out to the entire hospital. So it has to start in the classroom, to your point, that we want students who understand that this is very unique, and that care delivery is in fact better when you're trying to advance those 6 aims of the IOM. And I would say that you need to have students who understand that the traditional way of educating people is not what's best for them going forward. And then I would say a lot about process improvement. Are you all going to take an exam? I'm heard that this is exam time.
Yeah. We have students that leave at 1 because they have classes.
Good luck.
So I have a question for you. I think one of the things we've done very well in terms of our faculty here at the Westbrook College of Health Professions is culture change, is that we play well together now, and we don't think as much in the silos that we used to. We collaborate in a lot of projects, and some of our interprofessional efforts are kind of invisible because we just do it. But making the next step to working with clinical entities it's not just a step, it's a grand leap. And so I'm curious about how you worked with the institutional clinicians and administrators, getting them to think about that kind of culture change.
So within the hospital environment, we brought forward this notion of changing the way clinical education was done, and we asked units to apply to be the first. So there was a bit of competition, which is always good, right? Right? Competitions, you always want, some people want to be leaders and others want to be followers. So this unit, which was a really good clinical site and had a mixture of very acutely ill patients, to us seemed exactly right. I actually decided I didn't want this unit because there aren't many cardiac surgical patients that need speech language pathology. The director of our program said, we want to participate in this. Why would you select that unit? We don't get any consult requests from that unit. Guess what happened? Consult requests have escalated because the team never thought about what a speech language pathologist could do for this patient population. So already quality was advanced, but on our end it was competition. On the part of the school it was easy because it's our school, right? And we went to them and said, we want to do this. We really want to advance this idea. And it was even easier because I'm on their board of trustees, and started asking that question in the trustees meeting, why weren't we doing interprofessional education? It's going to be hard because you might have partners here in the local community that would be afraid of this, but then we need to help you, right? Schools need to partner with the local organizations to advance this. You all are working in some fabulous outpatient and primary care sites in some different facilities. I think that having this conversation outside of acute care would also advance care around the state of Maine. And it might be some of what the Lunder-Deneen folks can help us to think about, because they've talked to just about every organization in the state and who is thinking about this, that in fact we could help to facilitate that partnership. I just think there have to be organizations that want to be on the cutting edge. We need to break these barriers down. Thank you.
That was great, and I think I really appreciated Shelley's question, because it was the first one on my mind too, is how did you address some of the cultural changes? As you may know, as you alluded to, that we've been on a very parallel journey. I mean, I think for a number of us, we've been exchanging looks because your story is something we've experienced,
Right.
but we've been working in the outpatient settings, thanks to Shelley's leadership and Clay and Betsy and many others who are here today and others outside of this, this room. So, but I think and correct me if other people feel differently, but it seems like one of the biggest challenges we faced is we do have champions in a number of clinical settings who are willing to work with us on implementing interprofessional clinical rotations in these outpatient settings. But a number of the clinicians in, I would say almost all of those settings, they're saying, you know, we get it when you give us the data on medical errors and the talk on interprofessional competencies, the importance of it, and team and all that. We get it, but you know, there's so much going on in healthcare transformation.
Right.
And don't, you know, add one more thing on our plate. We can't do one more thing. And so the challenge has been find the sweet spots, the champions, the places where, you know, we think we can come in with this model with students and it's additive in a way that is helping the work and not adding more responsibilities or roles and responsibilities. But so love your feedback on that. But also, I would, the evaluation piece has been a big challenge. So
Huge.
I don't know if there is any way we can have a discussion sometime outside of this room on. I would love to learn more about how, you know, how you're evaluating this. We've also used, thanks to Shelley and others, the narrative approach, which was frankly very new to me, and I was kind of skeptical of, to be honest. But it's been very. I've learned, and it's been very helpful. But it has to go beyond that. It has to show the impact on long-term impact on students and clinicians and patients, very importantly, as you mentioned. So I don't know if there's an opportunity for us to continue a dialogue to learn from each other on evaluation. That would be great.
So the first point around change. Change is enormous in healthcare right now. We are really trying to reinvent ourselves. We are doing everything to reduce costs, to improve patient satisfaction, to improve the satisfaction of our workforce, to improve all of the outcomes associated with each discipline as well as with the team. And I have to say that if you're allergic to change, you're working in the wrong industry right now. You really are working in the wrong industry. And again, I would start out by trying to find partners that would welcome something very different. And this is hard work in the beginning. It feels like additional burden because the nurses are trying to learn what the speech instructor is thinking about, what the physical therapy instructor is thinking about. They would not say that today. And so it really, I mean, back to the example of patients now getting speech consults on the cardiac surgical unit. The staff would say it's better care, but it also has made that whole delivery system a whole lot more seamless. So the burden of work comes down after you create the change. And you know, it's not going to be easy because you work in a state with many, many different organizations. There are very few major healthcare delivery systems where you could go and sell this idea. And again, I would say we would be happy to partner with you. I also would say that take a look at the new, so in nursing, the magnet hospital requirements, the new standards really are starting to talk more about interdisciplinary practice as well. And we just had our magnet redesignation site visit maybe about 6 months ago, and the reviewers really zeroed in on the teamwork. So you have a magnet hospital in the Maine Medical Center push it. Just push it.
And I should just mention that a number of the successes that you have found in those narratives, and both from the clinicians and the students, we've had very similar results
Right.
in the several places that we've implemented these rotations. And so it was funny to see the quotes up there.
Right.
I mean,
Could be
yeah,
anywhere, right?
Almost exactly the same
Right.
quotes, as Shelley would say. So it was very.
The second question you brought up was regarding evaluation. And I have to say, this is the part that makes me the most nervous, because we are basically changing everything about the Massachusetts General Hospital. We have new patient care delivery models. We have new roles for staff nurses that we never had before. We are connecting inpatient and outpatient. We have inpatient nurses seeing patients in outpatient facilities. And so how are you evaluating this in the midst of all of that? We have teams for teams right now.
I just had a comment about the statement that we often get that response, people, I can't do one more thing. And I think it's really incumbent upon us to change that conversation. We all, I think, would agree, it can't be about adding something, it has to be about transforming the way we practice. And often, the argument I would make is we actually are taking away things that they're doing. And there's a good, I think, analogy for our pharmacy students that are here today is, you know, most of us know that a patient on 12 medications will probably be much better off if they reduce that to 7 or 5.
Exactly.
Because those have been additive. They've been adding one more thing, complicating their lives, increasing iatrogenic effects, and so on. So anytime I hear that response, I always say, what if through this process we would take things away from your practice rather than adding to?
It's a great point. I was in a meeting the other day where there were just two very different responses to this notion of pharmacists doing discharge education with patients and doing med reconciliation. And I'm thinking, this is great. Who better, right, to start helping with this work? Who better? The person sitting next to me, I thought was going to explode. This is nursing's work. You can't do this. And I'm thinking, you have got to be kidding me. Right? It's what, forget about adding work, taking work away. What's best for the patient? What is best for the patient? And if we think in those terms, then we're going to come up with the right answers. But I would say it's the coalition of the willing to start, right? Do tests of change with people who believe that change is needed, and make it competitive. Make it competitive. Have people participate in all of this and see what happens. My experience, 2 years ago, I was asked to lead this system-wide initiative with a physician colleague from another hospital to look at how to improve care delivery. At the same time, we were going to reduce healthcare costs by 6%. And we came up with this term, innovation units, where we wanted to do tests of change. And I thought that we were going to, there are about 60 inpatient units at the MGH, and I thought we would start out by doing 2. So we did formal presentations, et cetera, on what we were trying to accomplish, and we asked for 2 units to volunteer. And they had to go out and ask physicians, nurses, therapists, social workers, interpreters, everyone, if they wanted to participate. 12 units came forward because they wanted to change. They knew they had to change. Everybody else was like, oh, this isn't going to work. And what we realized, by sending help, we put almost all of our organizational resources in these 12 units for the first 2 months. Project managers, clinical specialists, educators. So they were getting all of the attention. Everybody else is saying, well, what about us? And so we made it competitive and we gave them some resources. People would not go back now, would absolutely not go back now.
This
Dr. McAfee.
Jeanette, first of all, thank you for coming, and let me congratulate you on what you have done and are doing down there. It's just an immensely important thing. And let me tell you why. I had the opportunity to be president of the AMA back in 1994-95. It was a time when the doctors and nurses were not getting along. Probably the epitome of antagonism existed. AMA even was developing a registered care technician, a new caregiver at the bedside, taking the position of the housekeeping, saying, the nurse isn't in here very often. We need somebody to help you eat your breakfast, etc. So I was able to say, it's time for us to develop a policy on collaboration, to come together as two large organizations. And so we orchestrated a meeting at the American Nurse Association headquarters in Washington. The three presidents from the AMA plus the CEO, three presidents from ANA plus the CEO. We started at 9:30 in the morning, we went till 3 o'clock in the afternoon, we hammered out a one-paragraph statement on collaboration. It was built on mutual trust and respect and training, but predominantly on patient need. And I was so proud that day that we had developed that it was going to be now the hallmark, particularly where both of our organizations were involved in accreditation of myriad programs across the country. And this would be the hallmark. Statement came back, both of the boards met the following week, and both organizations shot it down. And what it told me at that time, and to this day, is that when you're elected to that position, you're expected to espouse the policy of that organization and not something which is not policy of that organization. And everything that has changed in medicine and nursing since that time has evolved from something close to the bedside, something that has benefited the patient at a local level, in a local institution or a local hospital, and then become regionalized, statewide, brought to the national, and then the leaders were convinced at the very top that finally this was a good idea. I think the model still exists, and so that's why I think institutions like yours, institutions like this, whose primary concern is in education, we continue that. We had a modest initiative here on this campus, the I2H2 project back in the early 90s. Interactive, interdisciplinary health and healing. It was saying we've got all these different silo-taught professionals, and we don't have a common educational goal in ethics, in medical healthcare education, in healthcare financing, in health system reform, and all those things that are common to all of us. And so we began a very modest effort in trying to do that. We couldn't seem to convince the powers that be that this was better than the silo education. So it was abandoned to a degree, but I think it's coming back, and I think the work that you're hearing of today going on continues that legacy, which I'm terribly proud of. It is important. So don't belittle what's being done at the local level, because if you are in the ballpark with the patient, and if you understand that patient need first and foremost is what's going to dictate the future, then you're in the right place, and your example should be followed across this country.
Thank you. I always say, put the patient in the middle of the conversation. If we could just remember that, all of these silos would start to break down. You cannot justify a siloed mentality when you're talking about the patient.
Thank you so much. I think this really validates what we're doing here at Westbrook College of Health Professions and across the university with all of our colleges. I wanted to get back to your evaluation piece, and you were talking about how you were collecting narrative data from the students, but I'm hoping you're also collecting the narrative data from both the clinical instructors as well as the clinicians.
I'm sorry, yes, we are.
Okay.
Yes. We, it was easier for us with our own staff. Writing clinical narratives is part of the annual performance review.
Okay.
So our staff are very well versed in writing narratives. So we already had that in place. We just had to write a few extras associated with this. So thank you for that pickup.
Yeah. And I was thinking focus groups with
Right.
those different groups also would be another great way to
Yes.
triangulate that data. Nice.
Thank you.
So I have another question. Oh, let me give it to Elizabeth.
Good afternoon. My name is Elizabeth McClellan, and I run an organization called Partners for World Health. And we provide medical missions to 4 countries in Africa and a couple in Southeast Asia. And I just want to comment about this model because it's not evident, as you can imagine, in many other parts of the world, but it is evident in one place in Dhaka, Bangladesh, in a facility called the Center for Rehabilitation of the Paralyzed. They don't call it this, not at all, and they probably don't even realize that that's what they're doing. But they have nursing, physical therapy, speech therapy, they have occupational therapy, and they're all working together in this interdisciplinary mode. And it's really amazing to think that they've developed that without all of us trying
That's
to help
great.
them. And it's really great. And they're challenged because, the country's challenged because of the lack of nursing staff with 17,000 nurses for 160 million people. So this is the way to go, for sure. And to be able to know that there's some other place out there and to acknowledge that really will make them even do a better job and to really articulate it with them.
It's a great point. We don't understand the riches that we have in healthcare. I do a lot of global health education and a lot of volunteer work. And to your point, I think it's like now 10 years ago, I was in Uganda. And I'm watching all of these physicians that are rounding. And I'm thinking, where are the nurses? I already knew there weren't respiratory therapists and physical therapists, but I'm thinking, where are the nurses? And so I found 2 nurses that were in what I would call a closet. It was, in fact, their workroom. And they were folding bandages. And I said to them, how many patients do you have today? And the day started out with, there were 150 beds in this hospital. Every one of them were filled, and there are patients lying under the beds. So there were over 200 patients in this hospital. And as the day went on, the lawn gets filled. People are bringing their mats because they want to get into the hospital. So I say to these 2 nurses, how many patients are you taking care of? And they said, all of them. So we do need interprofessional care, right? Because there were about 20 doctors and 2 nurses. So we need to get this right because everybody around the world deserves excellent health care. Exactly. Well, this has been great. I would encourage you to keep going. You are way ahead on thinking about interprofessional student education in the communities. We'll help you to find an acute care facility to begin to do this, but your work is great. So thank you, and I want to wish all the students good luck on your tests this week. I heard it's test week, so thank you for having me here.